Today I put together a brief didactic related coincidentally to the case that we just heard about using opioid antagonist therapies in the setting of opioid use disorder. And so the antagonists available right now, they're FDA approved, or Naltrexone preparations, and so I'll be talking a little bit about what that looks like. I'm putting this up simply by way of review, probably something that you'll see frequently during the course of these sessions, just to remind folks about what we're talking about when we're talking about a use disorder, which is a term that is the clinical term in the DSM-5, the Diagnostic and Statistical Manual of Mental Disorders, that is frequently used interchangeably with the term addiction, a term which does not appear in the DSM and never has, interestingly. Point to make that I think is important for providers seeing patients that may be struggling with these things is to know how to distinguish physical dependence from a use disorder, because they are not the same thing. Tolerance, as I'm sure you know, is a phenomenon where an individual escalates use, needs to use more to obtain the same subjective effect, or they achieve less subjective effect with the customary level of use. And withdrawal, they experience the classic withdrawal syndrome, in this case from opioids, with a dramatic reduction in use or cessation of use. One thing that's important to note, again, particularly say, for example, in the setting of managing chronic pain with opioids, is the stem of this definition involves maladaptive use. So maladaptive use resulting in repetitive consequences in more than one of these areas over time. And so if someone, for example, is on opioids daily for chronic pain as a part of a multidisciplinary care plan, if they are tolerant to higher doses of medication, and if they perhaps experience withdrawal, if they've been adherent to that medication and other aspects of care and their function and pain are improved, then those criteria don't strictly apply. And what you're looking for, the remaining criteria that provide some indication of compulsive use and a loss of control over use, resulting in these consequences in their lives. And this is what opioid withdrawal looks like. Material with which I'm sure some of you are also likely familiar. And these are the symptoms that you tend to see. A lot of flu-like symptoms, but much more severe than your typical flu. And the duration can vary a bit depending on the opioid that you're talking about, whether it's shorter acting or longer acting. This is important to know some about in the setting of managing opioid use disorder with a plan that involves an opioid antagonist, because patients are going to need to go through some period of withdrawal in order to get to the opioid antagonist. Because again, if you give them Naltrexone, the antagonist, when they're actively physically dependent on the opioid, they'll go into precipitated opioid withdrawal. So package insert recommends a period of 7 days opioid-free before they receive the Naltrexone to make sure that they don't experience that precipitated withdrawal. And there's a fair variety of potential dosing regimens for clonidine out there in the literature. This is one example of such a regimen that was in Cochrane database review. So for those not familiar, reviews that assimilate a fairly large array of evidence. So that's a resource I've come to have some faith in. Clonidine is an alpha agent, and so it can provide some relief from those sympathetic effects, the anxiety, tremor, or hot cold flushes, but that leaves you with a lot of other symptoms that we need to manage and make sure they're not contributing to an increased likelihood of lapse. So checking in with patients fairly frequently during this course to make sure they don't need additional management for the insomnia, the diffuse pain, lacrimation, rhinorrhea, meaning watery eyes, runny nose, nausea, vomiting, diarrhea, abdominal cramping, and intense anxiety and dysphoria. And if there are questions, I can go into some details around those medications that we'll sometimes use. There are some other ways to get folks through withdrawal, and actually tapers using Suboxone have been a bit more successful in controlling withdrawal symptoms and in patients successfully completing that taper. The complication there, of course, is then once they finish that taper, they still need to be away from the Suboxone for no less than 7 days before Naltrexone is started. So there's still that issue if that medication is used. And again, that requires for physicians completion of 8 hours of online or in-person training or combination to get the additional DEA waiver to prescribe that medication for detoxification or management in an outpatient setting. There are also some less evidence-based things out there with rapid and ultra-rapid detoxification that I put up here simply because patients may ask you about them. And so it may be helpful for you to have some knowledge that these have been out, that these are out there, that they have been studied. And what the studies tell us is that there's poor retention, poor rates of recovery, and ongoing adherence with follow-up medication regimens with these for the most part. And the rapid detoxification involves giving people oral Naltrexone to get them through the withdrawal course more quickly on an outpatient basis. And then in addition to that, you're providing the clonidine and other medications to keep them comfortable. The ultra rapid actually involves putting someone in a hospital-like environment, sedating them and intubating them, and putting them through withdrawal course even more rapidly with naloxone. Those programs tend not to be covered by insurance and are fairly expensive cash on the barrelhead kind of programs. And again, you know, the detoxification is not treatment, and then they're leaving that environment and at risk for lapse and at risk for overdose when they leave there. So if this is something your patients are pursuing, that's an important piece of counseling around being sure that they're tied into appropriate follow-up after that. But generally, particularly the ultra rapid, I believe ASAM has a specific position statement indicating that they don't recommend that particular modality. So what forms does Naltrexone take? I've alluded to this. There's an oral daily formulation, and then there's the monthly injectable formulation. You see the doses here, and I'll just talk a little bit about what those look like and what the evidence is like around those. So oral Naltrexone, you know, the studies have been a bit all over the map, but indications on balance seem to be that oral Naltrexone doesn't work particularly well in traditional outpatient settings. If you give someone a prescription for 30 days of Naltrexone and say, be sure to take this every day, that tends not to work very well in the setting of opioid use disorder, with adherence being kind of a primary issue so far as that goes. So when it's been compared in studies to placebo with or without psychotherapy, there really hasn't been any marginal benefit to oral Naltrexone under that sort of framework. The injectable monthly formulation may overcome some of that, because again, it's a monthly injection, and some studies have borne that out, indicating that things like treatment retention are improved, time to relapse is improved. Some of the things that the studies have pointed out, though, that you probably already guessed based on some other things we've been talking about, is that it's difficult to get people on the medication, and that's been the case in these studies as well. So that's a real issue. It really takes a lot of support to get people through that period of abstinence and onto the injectable formulation. And while we have a lot of data out there, especially for methadone, some for buprenorphine preparations as well, around actually saving lives, preventing death, preventing blood-borne infection transmission, we don't have those data yet for either of the Naltrexone preparations. So then by way of getting back to the precipitated withdrawal discussion, so in the setting of Vivitrol, I haven't seen great guidance on that. And what we ended up doing in a particular case where we actually had it happen was using buprenorphine, since it has a much higher receptor affinity and the opioid agonist activity. We did that in an emergency room so they could be closely observed. And I was collaborating with the emergency physician in that setting, and that's what we ended up needing to do there. And that actually worked out well. The patient received 3 sequential doses spaced apart by 1 to 2 hours, and then their symptoms were pretty well relieved, and he felt good enough to leave the emergency room against medical advice.
Yeah.
And
there's that.
Okay. You know, and a week later, it was a week or 2 later, he was still reporting some residual withdrawal, but still felt like that was relief. But yeah, with the Vivitrol, that can be a really challenging one. Have you guys seen that in your?
Yeah, that was why we never go directly to the Vivitrol. We have worked with doing some really clear patient education that when we ask you about your use, and of course we do the urine too, here's why. Your being able to be accurate with this is going to have a definite impact on how you're going to feel in the next little while here. And so we've only had one recently, and that was actually with a Suboxone induction. She hadn't been quite as forthcoming as was felt. But even the precipitated withdrawal there was pretty uncomfortable with her. And I had a couple of emergency calls on it. We were able to manage her. I actually had them just stop giving the Suboxone, interestingly enough, and do the other supportive stuff when she came through it. And within 3 hours from the beginning of the induction was feeling well enough. And then we rescheduled her for a different induction, did supportive stuff, made sure she had her Narcan, that kind of stuff, and a counseling appointment. So it turned out okay, but it was the first time the staff at this clinic, because it's a new clinic, had seen precipitated withdrawal, and they were kind of excited about it. And it wasn't even a bad one. So that was why it's really, if there's a YouTube of precipitated withdrawal, it'd be a wonderful teaching tool for people who've never seen it, because it is very frightening. Yeah. It's not life-threatening, but it's very frightening.
Yeah.
Sheila, you should put that together.
Yeah. In my spare time, Catherine. Would you come be my patient to act the role? That's right.
I'm there for you. I'm there for you, Sheila.
All right, I appreciate it. We will plan for that, Beth. But it would be a really helpful